everyone. I'll just give you a few minutes to join. Sorry, I'm 1 minute late. Ali, I'm here. I'll just put my... Hi, Jacqueline. You're muted, but...
Now, I'm unmuted. So, how are you?
Hello, how are you?
Well, thank you.
You look different, Helen. You're very fancy.
It's what I was... It's one.
I'm not running. I'm not running behind the kid.
Well, when you saw me earlier, I was juggling with a lot. Actually, at the time, I was trying to feed my 1-year-old. It's 30 something degrees in London, and
Wow.
he had just pulled something glass from the cupboard, which had smashed, and my foot was bleeding when I was talking to you. I was like, I don't think there's really much more I can cope with right now. But yes, I look much more together, which wouldn't be hard from earlier. But the reality is I'm probably just as frenetic because I've just done bedtime. Anyway, we're here and there's already 160 people joining us, and we'll let them continue to join just while we get ourselves set up. And then we've got the recording if anyone is wondering. People always send in lots of questions. Please do send in lots of questions to use the chat function, and we can answer your questions at the end. We're going to leave some time to answer questions at the end. I will be trying to navigate through the many questions that come in just so I'll try and group them. And when we see themes, or when I see themes of different types of questions, I'll try and cluster them together so that we can really get an impression of urgency of answering these questions. So what I'll do is I will just get the slides. So essentially what we're going to be doing tonight is we're going to be talking about the journey in phases. So let me just go back to this and see where we are in terms of numbers. Right, we'll get started. So I'm going to kick off this webinar and really give the most warm welcome to Jacqueline, who is sharing her journey with us, and Dr. Florencia from ReproMed in Ireland, who is going to share her expertise. And really, we just wanted to be as casual a conversation to make people really informed just about the journey. But so often, so we've had multiple webinars with Hertility, and we have experts in egg freezing, we have embryologists, but actually it's really important to do this from the patient's perspective, because at the end of the day, the questions that you will ask yourself are different from the types of questions that we ask ourselves as professionals within human reproduction. So I want to just firstly give an introduction to myself. Dr. Florencia, I'm going to let you give an introduction to yourself, and Jacqueline, you the same, just so people get an idea of who it is they're talking to. So I am Dr. Helen O'Neill, and I'm an associate professor in reproductive and molecular genetics at University College London. I've been there for the last 10 years, lecturing master's students and medical students, and running my own research in early embryo formation, looking at all of the different genetic signals that really give us clues to the health of an embryo, and using genetic engineering to maybe look at ways that we could prevent or cure or correct different genetic illnesses. And about 6 years ago, I was probably in the position of you, Jacqueline, where I was thinking, do I need to freeze my eggs? Am I in the position where I can wait? Do I have enough information to equip myself with the knowledge that I need in order to make quite a substantial financial and psychological investment? And really found there was nothing in between the clinic and me. I was like, why is it that the first stop is to either be referred for fertility treatment and not be able to get answers just in a more convenient way? And that's really how Hertility was born, was to say, can we use a more complex architecture to understand somebody's risk, to understand somebody's potential conditions that might affect them, and to really just better understand what your own personal fertility was, not just generalized statistics, not the 1 in 7 or the 1 in 3 that has a gynecological condition, or the 1 in 10 with PCOS. You yourself, based on your own personal history, your medical history, your lifestyle exposures, your age, your family history, your menstrual factors, your symptoms, all of these things form this very complex calculus of what ifs, but also are very powerful in predicting whether you have a gynecological condition or whether you might have reduced fertility. So I too was in your position, Jacqueline, but also wanted to find help. I ended up trying to set something up that essentially answered the questions that I found myself unable to answer for my friends, because I felt like, well, first we do a test, then we do this, then we do the other. And I thought, well, we can do this outside of the clinic. So that's me. I have a background in molecular genetics, and that's really my passion. And Dr. Florencia, I will pass over to you.
Thanks, Helen. So yes, I'm Florencia. I'm originally from Argentina. I did my medicine degree over there, and then I moved to Spain, to Barcelona, beautiful city. I did my specialty in obstetrics and gynecologist, and then after a few years working on that field, I found also many patients struggling with their fertility. So little by little, I moved to the fertility area. And then there was a point in my life where I needed a change, and I had the opportunity to come to this beautiful country here. I've been here now 9 years in Ireland, in Dublin. I worked in 2 different clinics, and look, I really find absolutely fascinating the fertility field, because it's so complex. There's so many things and so many angles that we need to look after each couple or each patient, and it's very, very complex. As you were saying before, it's really not about statistics, but we need to be the person that is behind that story. So yeah, that's a little bit me. Probably I could talk much more, but that is going to be very boring. But yes, so if you have any questions, then I can answer that. But the idea will be, as you said before, just to have a more interactive kind of communication today. So we'll be very happy to listen to Chuck's story from a perspective of a patient. I was a patient myself as well, so I suffer with infertility, and so I was there, and I know what it means to be on that side of the scene. So yeah, I know all the struggles and the difficulties. And although I had all the information myself, because I did all the specialty in this field, but still emotionally and psychologically and physically, I had to go through that process. And I was very lucky to have the right people around me that really helped me to go through a process in a very positive way. And I had 2 beautiful kids born from IVF. So yeah, that's a nice story that I like to share.
It's nice to be on both sides of it. It gives you total perspective into your own patients.
Absolutely.
Amazing. Jacqueline, do you want to tell everyone a little bit about you, and then we'll get to the format of the webinar, which is essentially all around just the different journeys, the different phases of, I guess, decision making when it comes to, I guess, sometimes fears or assumptions or insecurities versus what happens in reality. And I think that personal experience is really valuable to everyone who's here tonight. So let's maybe start with your background and just really just your mindset on exploring egg freezing.
Okay, so just to give a little intro, I'm Jacqueline. Some people call me Jack. I'm 38 years old. I don't have any kids at the moment. And I'm originally from Limerick, but I've been living in Dublin for about 15 years. I work in a very different industry to the medical industry. I work in financial services. But I'm very lucky in that I work for a great company that supports fertility journeys, whatever that may mean for the different individual employees. So I was really lucky to work in a place where that was the culture as I went through the egg freezing process. And I froze my eggs in January of this year. So that's a little bit of background.
Okay. I remember first hearing about companies supporting egg freezing and thinking it was amazing. Then I went full circle and thought, actually, I'm not sure how I feel about companies just paying to freeze their employees' eggs, because the message it possibly gives is that they don't support them just having a family. And I think for me, offering choice and offering early screening is really important. That's why we work with a lot of employers. We work with Irish Life Health to offer earlier screening so that people can make an informed decision before necessarily going all in. So So we just wanted to kind of start with some questions really for you, and then maybe where your mindset, I guess some of the journey that you had when it comes to making this decision. Do you feel that it was, had this not been offered through your work, or that they were supportive, that you wouldn't have been aware of it? Or is that how did you first become aware of egg freezing, or is it just that it's become so popular now?
It was a myriad of factors. So my work don't, so that's really interesting take, because that's one thing they don't do, is they just offer fertility leave, and they just have a lot of supportive webinars for people. I think it's mainly for people who are dealing with miscarriages and different, you know, it seems kind of incipient at the moment. And at every employee forum, I'm always asking, can you pay for it? But that's an interesting take that you have. I suppose it could be perceived as that. But it was a myriad of factors. I think about maybe 5 years ago, I'm with VHI. I'm lucky enough to have healthcare with VHI. And when I rang them, I asked about the fertility benefits, and they mentioned that they were affiliated with ReproMed. So I think at that point, subconsciously, just had decided I'm going to go with ReproMed. And I didn't know whether that was going to be full IVF, if it was going to be just needing tests, if it was going to be egg freezing. I just thought, you know, I was 33, we were all in lockdown. I didn't really know what I wanted to do with my future, but I wanted to kind of put that decision, have some sort of support there. So I think that's how I chose it. And I chose the clinic. But I'm lucky that I have a few friends that have gone before me in this path as well. So because I'm 38, like a lot of my friends have decided to go down the egg freezing path also. So I had I was constantly on the phone texting them at the time, asking questions. But I'm lucky that I have that network, and I'm realizing now some people might not have that. And I genuinely, I don't know where you would get information. You know, I had a direct line. So yeah, that's really what I was thinking and my thought process, but it was sort of subconscious.
For anyone who is wondering about the process and how it works, we have an extremely put together guide all about freezing your eggs. We have another one on making babies in same-sex relationships. So we've got lots of different information for anyone who's wondering and doesn't have a friend that they can call on to say, how did it go? What was it like? And just that isn't so familiar. So then when it came to booking, a lot of people have a real difficulty when it comes to choosing the clinic, understandably, because what you're selecting really is kind of your future. You really want to put your hands in like very safe hands, or your eggs in very safe hands. And this is something that we over here, we have been extremely selective, as you can imagine, with a background looking at eggs and embryos and working very closely with embryologists. You become very selective with what clinics you would refer patients to. So we only refer to clinics that we really know and trust, ReproMed in Ireland being one of them. And but what brought you to that decision, and how did you find ReproMed?
Yeah, so I think because I really liked VHI, and they were a trusted brand, and they're a trusted brand for a lot of Irish people. So I think subconsciously with that, I just assumed that ReproMed would be the best clinic to go to. And then when I did contact ReproMed initially, at every point, everything was seamless and helpful and supportive. And I never actually second guessed my choice at any stage. But none of my friends that had gone through it had actually gone through this clinic. So it is interesting now that I'm looking back thinking, how did I make this choice? Because I didn't feel like I had to sift through a huge amount of information. I just knew, and I think it was the affiliation with VHI. We do tend to only, VHI would tend to only go with to affiliate themselves with other trusted brands. So in my mind. So I think that's why I went down that route. And then at every stage, it was just quite easy. So when I went to contact them in November of last year, ReproMed, I am a millennial, so I hate making phone calls. So I requested, honestly, it was so seamless that when I'm trying to think back on it, I'm wondering, what did I even do? Because it just was so natural and easy. But I requested a call back. And then somebody rang me, and then they sent me all the information in an email. And just at every stage, it was so professional and friendly and supportive. And the only thing I ever kind of held back, and you said it yourself at the start, it's a psychological and monetary investment.
Mhm.
So I knew that it might be hard on my body and it might be hard on my bank account. And that was the only thing that ever kind of held me back. But the minute I got into the process, I was delighted, because there's no better time to do it than right now. The longer you wait, the less
You're only
chance
getting
that you
you're only
have.
getting older and less fertile every single day.
Yes, yeah, I don't want to say that, but
Yeah, no,
yeah.
I've gone to that because so you know what? Some people need to be just shoved off the edge. I'm like, just do it. Think of it as 2
Yeah.
weeks of your life, 2 weeks, and you're done.
Yeah, you
You know.
really need to just go for it. I was so happy that I had done it. And by the end of it, like, especially with the VHI connection, I didn't actually realize what the benefits would be, but the payment is so seamless. Hi. The payment is so seamless. And usually with VHI, you pay up front and then you claim back the cost. But with VHI, the clinic actually claim that straight from VHI, so you're never actually out of pocket. So everything was actually a lot smoother than I had even anticipated. So yeah, at every stage, I never second guessed it. And I guess in a way, I was just lucky that it all just worked out so well. But again, as you said, everyone's experience is different, but I just had such a positive, empowering experience. And I think that's why it's important to do these sessions, so that everybody can go in with the information that I had to kind of pick up over the 5 years.
Okay, amazing. I'm going to run through some slides just to bring it back to give people some visuals. We've talked about the exploring and curious phase. You're booked and you're prepping for the treatment. And then what I wanted to talk about a little bit with Dr. Florencia was really just bringing it back to biological basics and why people might want to freeze their eggs. So Dr. Florencia, do you want to talk through this graph? This graph, which was, by the way, probably what inspired me / terrified me into starting Hertility, because as you can imagine, working in this field, every conference I went to would show this graph, and I would look at it, look at myself in my 30s going, oh my God, oh my God, like, where am I? I
Yeah.
feel like my fertility
Well,
free fall. I need to do something about this. So do you want to talk us through it?
yeah, definitely. But what I want to say is that it's not the best to freak out. So the best to do is to have the awareness
Sorry.
of everybody's situation, to understand better our fertility, to understand better our choices, so we can freely decide what we think is the best for us. But I don't want anybody to feel worried about it. I don't want anybody maybe feeling guilty because I haven't done anything in the last few years. So many people is coming with that feeling. I said, no, if you didn't do anything, it's because it wasn't the time. So there are many reasons. So this is just for everybody to have a better understanding and to decide what's the best for you. But the reality is our fertility biologically declines with our age, okay? And that involves the two main factors, that is the egg, what we call the egg reserve. But much more than that, the parameter that changes and decreases our fertility is the egg quality. Okay, so that's important, because some patients at very young ages, for different reasons, they could have a very poor egg reserve, but then the egg quality is expected to be very high. Therefore, so their chances of conception are pretty good. And the other way around, patients who are at older ages, sometimes we have a very good egg reserve. And I've seen patients who are coming to see me after maybe 3-4 years trying to conceive, and they're maybe 43, 44, and they tell me, oh, because my doctor a few years ago, they said that my fertility was the same as somebody at 30 years of age. But that's because the egg reserve parameter was very good for her age, but the egg quality is the same as is pretty standard for everybody at the same age. So basically, so if you see this graph, I think it's very interesting to understand how the number of eggs or the egg reserve declines with our age. So the maximum number of eggs actually is even before we're born. So we start losing eggs when we're in our mommy's tummy, actually. So at the time of being born, we have more or less 1 or 2 millions of eggs. And even before we have our first period, we start also losing more and more eggs. At the time of puberty, there's only 400,000 of eggs average. This number is going to decline little by little, and although we have one egg ovulated per month, we lose many of them. And probably many of you had an internal scan, and we're going to talk about it after. You may have heard about the concept of antral follicular count. So this is the number of small follicles we have in the ovaries. So if you had a scan and they told you, for example, oh, you have a follicular count of 10 or 15. So those follicles we see are some of the eggs that we're going to lose on that month. But also there are many others that we don't even see them in the scan. So the follicle and the egg goes through a process of getting stimulated, because the egg needs to get activated and needs to suffer different kind of changes to be able to be inseminated with the sperm. And during this process, the follicle is going to get bigger little by little. So if you see on the right, actually it says that in every menstrual cycle, a woman loses more or less 1,000 of eggs. So that depends on our age, obviously. But for patients who are younger, so that's more or less the number of eggs that we lose. And this is the reason why. There is a number of follicles and eggs, which is approximately 1,000, that are going to be activated every month from all those. More or less 15, 20 of them are going to get into these antral follicles that we can see with the scans. And then from all those antral follicles, only one is going to be the dominant follicle that is going to release the egg. This is related with another factor that many patients, they ask me, oh, if I'm going to do this egg freeze or if I'm going to do IVF, as we stimulate the ovaries to produce more eggs, does it mean that my egg reserve is going to decline faster? Does it mean that I'm going to have my menopause a bit earlier? And the answer is no, because actually what we're trying to do is to rescue those eggs and follicles that are meant to be lost from all those thousands or hundreds or tens that we see in the scans. So with the hormones, what we do is to get them up to a point of being ready to have the egg at the time of the egg collection. And we rescue those that would lost if we couldn't take any hormone at all. But this graph shows how the egg reserve declines with our age, and the number is very low when we are in our mid-40s, early 50s. But as I said, it's mainly the quality that declines much faster. So the colors represent the quality. Red eggs are very good, and the whites are the ones that unfortunately are not going to probably give us a good egg and a good embryo.
And I think we used to really say a lot, like 86% of your egg reserve is gone by the time you're 30, which is kind of a harrowing statistic. But if you think about that from the other way around, you may have 100% of your egg, you're born with 100% of your egg reserve, but it's not like you're fertile then. So it's a little bit of a misleading statement, in fact, to say that we're, born with all the eggs, but it doesn't mean that we're fertile then. But we do lose a significant amount throughout life. And I totally agree. Sometimes the reference ranges for our AMH, which it's really like a surrogate marker for your fertility, really can be quite wide and misleading as a result. I think we show it here in the next slide. Just another steady decline on female age and essentially the percentage of eggs with normal DNA. And I think that's what is a difficult one, is when you see the number of eggs going down, what you can probably overlay with that is that increased risk of having the wrong number of chromosomes within those eggs as we get older. So the increased risk of what's called aneuploidy, that's kind of compounding this graph. So actually, even though your egg reserve might be large at an older age, you're still going to have to consider the fact that they're not going to be as good quality. Again, not to scare anyone, and everyone's lifestyle factors are quite different. And what we know from published research that we've done and globally, that there is a big impact that lifestyle factors can have on somebody's fertility. So how do you measure your ovarian reserve? I'm just going to start with the one on the left, and then you can take over with the one on the right. One of the things that we recognized was what we call a surrogate marker for your fertility is what's a marker called anti-Müllerian hormone, or AMH. So AMH is expressed by each of the follicles. So these are the would-be eggs. They're immature eggs, and unless you have enough hormone around them, they won't mature. So these each of the follicles that will turn into eggs produce AMH. So if you can imagine the amount of AMH you have is kind of a really good marker for how many eggs you have. So there's plenty of studies that have actually looked at how comparable AMH, which is anti-Müllerian hormone, and AFC, which is your antral follicle count, so physically counting the number of eggs you have on a scan, they're pretty concordant. But what we, as Hertility, wanted to ensure was that we would never measure AMH on its own, because while AMH is a really valuable marker for relative egg count and therefore fertility, what it doesn't take into account are all of the other factors that I talked about that I thought, what about age, previous medical diagnoses, any menstrual factors, any symptoms, any previous infections that you might have had. So that's why our test takes into account all of the different possible parameters before ever measuring AMH, but also we'll never measure AMH on its own. We measure it with FSH, LH, estradiol, full thyroid panel, your androgens if you are suspecting a diagnosis of PCOS. So it's really important to have a fully comprehensive picture of your fertility rather than just relying on AMH alone.
Yeah, one thing that I want to mention as well, because also something that happens to me is that some people comes thinking that their AMH is normal, because when you have a report, and this happens a lot here in Ireland, but I've seen also some reports abroad, if you have a test in the laboratory and they send you a result and it's going to give you a number, so your AMH is this number, and then between brackets you have what is normal. So you have from the very lowest to the highest level. But in reality, most of those reference ranges considers from the very low centile, like centile 3 up to centile 97. So what they consider normal is not the real normality. The real normality is what is where is the majority of the patients at this age going to have. So on this graph, actually, you can see 3 different colors, and they talk about centiles. So this is the reality of the normal AMH. So the purple line, the one in the middle, is the one what we would consider normal, but the one that is kind of blue, the one that is on the low side, that would be considered a low egg reserve. On the other hand, the one that is a little bit lighter, like cream color, it's over the centile 75, so that means it's a high AMH for that age. Sometimes could be associated with PCOS, but not always. And although it's not a real problem to have a high egg reserve, we prefer to have high egg reserves because we think, we have lots of eggs to work with, but sometimes could be associated with some other hormonal disbalances that is important to find, and if that's the case, to correct them. But if you have any questions, so what I normally tell people is don't rely in a paper that you receive from the laboratory, but get your test review with the consultant, with the doctor, to have a better understanding of your egg reserve. And as you said, because it's not only about taking into consideration one number isolated, but to consider the whole history, previous history in terms of fertility, health issues, or if there is any other risk factor that we may need to consider.
But you don't need to retest once you've gone to the clinic if you've done a fertility test, to clarify, because we've done.
Oh, no, for sure. Yeah. No, so people can bring the reports from any other place. It's absolutely fine. It's
exactly. It's good to have somebody talk through. It's actually why we created. We didn't just. It's one of the first things we did was to say, if somebody is presented with blood results, and we all have been at some point, where you look at them and it says your AMH is 5.8 out of a reference range of 3 to 100, and then it's an asterisk, and you say, what does this mean for me? And you panic. And when you're in the position of being a patient, no matter how confident you are, seeing results in front of you can be really daunting. And so we made sure that for every single thing that we test, whether it's AMH, whether it's your follicle stimulating hormone, whether it's estradiol, we explain what that hormone is, why did we test it, and what it means for you. We also explain what that result means for you in the context of your other hormones, but also in the context of your symptoms and menstrual factors and any potential diagnosis. So we have a very comprehensive, like 8-page report, but you can view it all through your app, and it gives you a care plan for which then you can book your consultation if you wish to just speak with somebody, or you can go and see you, Dr. Florencia, or one of our partner clinics. So really hoping to make the journey as understandable, but also just as smooth as possible. So The big question that people ask is, how many eggs do I need to freeze? So you do your test, you get your results, you have a relative idea of your fertility based on the number, based on a lot of things. So whether everything's within range, and you have your AMH result. How many eggs do we need to freeze? It's one of these questions that's very difficult to answer because, again, quality takes it into account. But do you want to talk us through this study that was published actually in 2016? Dr. Florencia.
Yeah, there are many other studies that were published after, but I like this graph a lot because I think it's very visual. So this considers age of the patient that is related with their quality and considers the number of eggs that were frozen. Okay, so, and what is the ideal number? There's not a short answer for that, because what it really matters is what are the patient's expectations, how somebody wants to plan their future fertility. Sometimes I have patients who tells me, look, I want to freeze my eggs, but I don't think I want to have babies. I just want to do it as just in case, but I'm not going to invest too much of my time, my money, whatever. So I'll do one cycle and whatever it is going to be, and it's fine. Some other people is all the opposite, and they tell me, oh, if I don't have a baby, I feel that my life is not going to be completed. So I really want to do something that increases and maximizes my possibilities as much as we can. So that conversation is very important, because normally what we do is when a patient finishes the cycle of egg freeze, and we know how many eggs were frozen. So we have these kind of graphs just to talk about, okay, with the number of eggs and considering your age, your possibilities of having a baby in the future, if you were to use these eggs, is going to be approximately, and we tell them 30%, 50%, 60%. So based on that, somebody could say, I'm happy with that, so I just leave it. Or somebody would be more like, no, I think that I like to reach a higher possibility, so I prefer to do another round. So these really help us to decide whether one cycle was fine and is good for that person, or whether somebody wants to do multiple cycles to get to the point of having a higher chance of success in the future. So overall speaking, so I'd say for everybody, I'd like to have at least 15 eggs. So I normally say, so more than 10 at least, because it depends on the age group again. But if you see there, based on that, at 30 to 34 years of age, with 15 eggs, we can get up to 70% chances, which is pretty good. But even at older ages, for example, at 38 to 40, with 15 eggs, we reach nearly 50%, 45, 50%.
So
I,
just to talk through the graph here, what I'm going to do is I'm going to give an example here, and I'm going to just pin. Let's say you are between the ages of 30 to 35 here. What we have on the bottom axis is the number of eggs. Essentially, I'm just going to say number of eggs, right? Because number of mature M2 oocytes that are vitrified.
These are number of eggs that were frozen, let's say.
This is the number of frozen eggs, right?
Yeah.
Because oftentimes you might collect 10 eggs and they mightn't actually freeze all of them. They may not look mature enough to freeze. So I just wanted to see if everyone could look at this part of the graph, if you were looking to have at least 3 children, and we're on the bottom graph here. So green is at least 3 children. The bottom graph is the number of eggs that you would probably need, and then your predicted probability of having those children. Of having those children, right? So actually, the more children you want, this green is obviously at least 3 children. At least 1 child, you obviously have a much higher success of having a child from that. So let's maybe follow. If you want at least 1 child, to guarantee 90% success, you'd want around 28 to 30 eggs. Now, obviously, this is quite different for some people, and there are other people who would say, that's all very fine, but I'm not going to get 30 eggs, and I don't know how I'm going to get 30 eggs. And in order to do so, you would probably need to go through multiple what are called rounds of stimulation, which we're going to talk about in a second. But the same is true to be said that you might get 2 frozen eggs, both fertilize, and you transfer one and you end up. There are many people who can console people with a low ovarian reserve to say you just need 1. But as a general rule of thumb, it's important to counsel patients that your success really is not dependent. You are not guaranteed a baby with just 1. That when we look at the literature and the average chance of having a successful embryo transferred and leading to a baby, you need a higher number of eggs to be frozen in order to have that guarantee. Is that more helpful?
Can I just ask, I can see some questions coming in here, and a lot of them are the questions that I had at this stage.
Great.
So would I be able to just quick
Yeah.
fire questions just so we can
Let's do it, because we were going to save
for
questions
me
for the end.
also.
Maybe we should just yeah, we should go to it. Go for it.
Great. Okay. So how long can my eggs be, so the eggs that you do get, how long can they be stored for, and what are the storage costs?
Yeah, in terms of cost, obviously different clinics will have different costs. In ReproMed, there is an annual fee of 450 to have the eggs stored. And in terms of the length, in reality, we can keep them for as long as you wish. The limit we have, it's more kind of a moral, ethical limit that is decided in Ireland and in the UK and many countries in Europe, is to treat patients up to the age of 50. So that means, imagine that you have your eggs frozen at 35 and you can keep your eggs for 15 years, and that's fine. Something that is important to consider is that the fertility techniques and all the technologies we have in the laboratory has changed so much in the last 10, 20 years for better, obviously. And that's why the success rates are much higher now than in the past. And we hope that this is going to get better in the future as well. So the only thing with keeping the eggs for too long is that now we can counsel the people about what are the chances of success expected based on the technologies we have at the moment. But we don't know what is going to happen in the future. So what is happening now, for example, is I have patients who had their eggs frozen for 10 years or 15 years. And the technology that was used at that time in the past was different than the vitrification and fast vitrification we use now. So I need to tell them, because your eggs were frozen in a different technique, the chances could be a little bit lower, because we expect to have a little lower thaw rate, and so we can tell what can happen with the technologies we have now, but maybe in the future could be something that hopefully is going to be even better than what we have now. But yes, it's basically for as long as you wish, up to the age of 50, which is the cutoff to treat patients in Europe, and 450 storage fee that you need to pay per year.
Okay, and you mentioned about success rates. A question that's come in is, are fertility clinic websites transparent about success rates? I'm not sure if you can comment on other fertility clinics, but just
yeah,
in your
so
opinion.
I can tell you exactly. In ReproMed, we are, and we have a quality system where we audit all the internal results. So to have our internal results audited, is so important. It's crucial for every fertility clinic, because it's the only way to know if we're doing things right. Sometimes very little changes in the environment inside the lab, or sometimes when we do a change in the medium culture, or even a small change in the temperature inside the laboratory, can change the results of the treatment. So we need to check that all the time. So we have every month, we need to report our results too. So we are part of a very big group in Europe that is called Future Life, and we need to report all our statistics to them, and we compare our results with other clinics in the same group, and we need to be all of us, we need to be more or less within some parameters. So if we are below that, so we need to review everything from all the perspectives to see what is going on, what we can do better. And because of that, we have a system that we get to our results and percentages of success monthly, and we go publishing these results in our website and different kind of social media. So it is transparent, yeah.
Okay, great. And one here that I had as well, and will it deplete my egg supply or lead to early menopause?
Sorry, can you say that again?
Will it deplete my egg supply or lead to early menopause?
Not always. So actually, there are many studies that try to find if a patient with a low egg reserve would have an early menopause. And there's not a direct relationship when the egg reserve is on a low centile. In some cases, when the depletion is very, very important, so for example, an AMH that is below 1, we know that most of those patients, they are getting into the perimenopausal area. Many of them, they start to have some irregularities in their periods. So when the levels are on the very low side, like the lower than the centile 3, it could be that the menopause could be coming earlier. But for other cases where it's low, but it's between the centile 3 and 10 or 15, sometimes, and I've seen patients where the egg reserve was low for many years, but it was pretty stable. Then we checked it 2, 3, 4, 5 years after, and it kept very stable. So this is what I normally tell for somebody with a low egg reserve is it's important to keep an eye on the egg reserve, because sometimes we see that declines much faster than in some other cases that would be very stable. Yeah.
Okay, interesting. Thank you.
So
Any
I'm
other
just
question, chat?
There's actually loads of questions. We have nearly 60 different questions. I'm trying to type some answers to some of them, but I really want to make sure that are more niche. But I want to make sure that we get to them. But I think what's a helpful guide for us is if we just move on a little bit to the treatment, so that we can talk actually a little bit about the nuts and bolts and how it works and the process itself. Because I feel like once you've made the decision, or when you're trying to think of the decision, the major considerations you have once you've gotten over the financial barrier are essentially where the average cost of egg freezing is around £4,000 really, or euros, 4 to 5,000.
Sorry, it's a bit less than that. So in
Pounds.
ReproMed, yeah, the cost of egg freeze is 2,200, and then you pay the storage fee. So altogether is 2,700, more or less.
Including meds, including bloods, including
yeah,
scans.
bloods are included, scans are included. You mean the ones I need to do before?
Yeah.
The ones you need to do before. So altogether it's approximately 300 extra. Yeah.
It just adds up. I think it's kind of, for me, I think by the time you
Okay,
actually
so you're thinking about all the pre-testing and everything.
Yes, of course, because you can't do it without it, right? That's why well, you can, if you use Hertility, really avoid some of those quite pricey blood tests within clinics, not ReproMed, but generally. That's why we wanted to create that pre-step, which allowed you to test your fertility and just make an informed decision, and actually then go for treatment, but not having to pay excessively. But I think all in all, when it comes to a lot of it, we tend to see that people end up having paid 4,000. And I think if we round up the figure, then people can reverse engineer the calculations on the number of coffees that they would have had in that month. Coffees now, £4. Just want to caveat this with, I used to do this calculation to say to people, if you cut out coffee for a year or something, right? If you were to cut out something expensive, and now I think it's actually probably only 6 months, because I got a small latte at Costa and it was £4.15, and I just was disgusted with life. But there we go. Now you just need to spend less time drinking coffee, and you'll definitely get to the price of egg freezing. But I thought if we talk.
Sorry. Something that I want to say, because we have audience from Ireland and also from the UK. In Ireland, we have the drug payment scheme, which is very good. Actually, Irish people is very lucky because they pay like a flat fee of €80. And this is important because the medication is so expensive, especially if there's a patient with a low egg reserve and we need to use high doses of hormones. People sometimes could be wasting like 2,000-3,000 euros only for medication. And here it's only like 100. It's Chuck, I mean, same, right? It's 80 or 100, something like that, right?
It's €80, yeah. And they
€80.
give you more than you need so that there's room for error as well, just in case you click the pen wrong, but you won't. But they give you a lot of it so that you have it there if you need it. So yeah, I'm sure it would be very pricey if you didn't have the drugs payment scheme.
That's great. We'll add a link to that for anyone from Ireland so that they have access to it. Okay, we'll take a little bit of an overview on the treatment, and then we can get to some more of the questions relating to the individual stages of the treatment. One of the words that we use quite flippantly is cycle, right? And I think when we're talking about number of cycles, it's not really quite clear to people what we're talking about when we're talking about the number of cycles. I'll come back to this in a second. But when we look at this egg freezing pathway, we essentially wanted to give an overview of exactly what you'd really be going through, because once you've made that psychological commitment, or rather the financial commitment, the psychological commitment is still what puts people off, because they say, oh, how long is it going to take? How long am I going to be doing this for? But actually it's quite a quick journey. It's done with it. When you think about, I always say, think about one menstrual cycle. In any one menstrual cycle, your body intends to mature one egg, release it, that egg waits around to be fertilized, and when sperm doesn't come, the lining of your uterus, which is building up for a pregnancy, says, right, no sperm, no fertilization, let's shed, and your period happens. So when you imagine that exact same menstrual cycle, But when it comes to stimulation, what you're literally doing is you are stimulating your body or stimulating your ovaries and giving yourself exogenous hormones. So you're giving yourself more of the hormones that would be naturally produced in your body, so that rather than your ovaries maturing one egg, releasing it, what you're doing is you're taking exogenous FSH, which is follicle stimulating hormone, the hormone that will stimulate these follicles and try and mature as many of them as possible. And instead of them just being released, what you're doing is you're essentially, after this ovarian stimulation, you are going to have a monitoring scan, and you have your egg retrieval here, which is essentially where you have a transvaginal ultrasound with a needle going through to aspirate or collect as many of these eggs as possible. So really important to say that this is something that you're kind of putting your normal menstrual cycle and the hormones that you would have and amplifying it so that you can capture as many eggs in that given cycle as possible. But I think all in all, this is really not so time consuming for an individual, which I think is sometimes the most off-putting thing. So Dr. Florencia, do you want to put that in your own words?
Yeah, sure. So, first of all, yeah, what you said is very true. Sometimes we say, well, that's fine, I have the money. But then you think about it, many people is thinking, oh, I don't know, it's very complicated. It's going to take time. I need to stop working. I won't be able to go to this concert that I want to go. So there are many things you consider. But I normally tell patients, you can really continue with your normal life. Obviously, on the day of the egg collection, because we do it under conscious sedation, it's not a very painful procedure. It's pretty fast. Normally it takes 10-15 minutes. We use conscious sedation that really help us to keep the patients more relaxed and with no pain. Jackie, you can tell us how was your experience with the collection. Actually, that would be lovely to hear. And also you see here like many steps, like I need to meet my doctor, I need to have a coordination call, I need to have a nurse call, I need to have my baseline. All that really happens. That looks like a lot, but all that could happen in a week. So it's really so we have a consultation. If somebody is clear about what they want to do, I can make a plan on at the same consultation time. Then I send the order to my colleagues. The colleagues contact the patients on the same day or the day after, and they organize. They go through all the process again to talk about similar things that involves cost, timing, consents, risks, how to use the medication is going to be more with the nurses, that you have a clear picture of everything. And then we say, okay, when the period comes, we are going to do the first scan. So we do the first scans, we do the bloods, we need to do the virology screening. So that's something mandatory. We need to do hepatitis B, C, HIV. So that's just a blood test. And we started. So I have patients where sometimes when they really know what they want to do it, and we have the consultation and they're happy, they want to, then they tell me, oh, but my period is coming in 2 days. Is that possible to start? Oh yeah, I call the nurse. I ask them, please call this patient. They have the first consultation, and everything starts very, very fast. Then the process of ovarian stimulation, that could be a bit, for some people, overwhelming, because obviously our hormones are going to be very high. But I have to say, and again, I'd love to hear Jackie's perspective of things, but I always ask the patients, how was your experience? How did you feel? And the majority of them, 80% of the patients, will tell me it was literally absolutely fine. I felt very energetic. I felt a bit bloated, maybe a little bit more tired, but nothing terrible. I could continue with my normal life. Many people is very scared of using hormones because they have heard very bad things about it. But I tell them to look, this is because normally people who had a very bad experience are the ones that talk the louder. So, but the people who had a very smooth process, they don't tell much about it. So I always tell other people's experience for patients before they start, for their peace of mind. And then it's the 2 weeks taking the drugs. Normally it's an average of 3 ultrasounds during those 2 weeks, where we need to monitor the growth of the follicles. We do some blood tests as well to monitor the hormonal activity. Egg retrieval, as I said, is 15 minutes, but you need to stay in the clinic for a couple of hours for the preparation before and for the recovery after. That's the day that you need to take off. But then again, many patients the day after, they're fine to go back to their normal duties. And on the same day of the collection, we will inform the patients how many eggs we got and how many eggs are frozen.
It's quite a profound moment when you're in the lab and they're counting the number of eggs that have. Okay, amazing. So I'm just gonna go back to this one to say we're really trying to make it as streamlined as possible. We want everyone to make the decision for themselves, whether it could, and only if it's the right thing to do. It's why we wanted to make the blood test from home so convenient that you could actually do it on the 3rd day of your cycle, not have to go to an appointment or physically leave your house to ask a very detailed health assessment, which is essentially like having a consultation with somebody to get your relative risk. One of the things we're really proud of with that health assessment that we do before you do the blood test is that we can screen for 25 different health states, but 18 gynecological conditions with 98 to 99% confidence, both precision and recall. And we have tested our machine learning models against clinicians, and it performs as well, if not outperforming. And the reason I say this isn't to put clinicians out of a job. It's the opposite. It's to put people in the hands of the correct clinicians that they need, because so many women we speak to end up on a little bit of a diagnostic odyssey if they have something wrong with them, whether it's IBS, whether it's confusion between endometriosis or anything else. We really have quite a sensitive way of triaging women through our health assessment and our blood test that you can do, which is essentially just a capillary blood test, which means you just prick your finger, meaning you're using less blood than you would if you had to give it from the arm, which is a significant amount of blood. And then really we can connect you with our clinical services that you can either speak to somebody to confirm or then be referred for a scan or for fertility treatment. So we are trying to cater to the busy woman, and we couldn't provide this end-to-end service without clinics like ReproMed that we refer to. And we've just gone through this slide. So then the next question is really about what happens once you've frozen your eggs. And what's an important thing to consider is that the eggs are frozen. They will need to be thawed, then they will need to be fertilized, and then that fertilized egg or embryo will need to develop and grow. And so that is multiple parts of a process when you think about number 1, freezing, number 2, thawing, number 3, then putting that egg with some sperm, either injecting it in, which is a process called intracytoplasmic sperm injection, or ICSI, or putting the egg in a dish with loads of sperm and may the best sperm win, which is regular in vitro fertilization, or a regular fertilization. And then placing these fertilized eggs or zygotes in a dish, and really we can watch them grow over time. And the way that we can really then grade them according to their quality is to look at the ways that they have grown. And we look for different features, and we hope that these early embryos that start with 1 cell and divide into 2, 4, 8, and then really start to grow in multiple ways up into what's called a blastocyst. And that is the stage that we would then transfer that embryo for a hopeful pregnancy, or you could actually again freeze those embryos afterwards. So there's lots of different considerations, but really the only thing that you as a patient probably needs to consider from an invasive perspective is the transfer point. So once all of this will happen in the laboratory, and then you'll come in and they'll say, okay, we're going to do a short little procedure to transfer those embryos, the best quality embryo, into your uterus for a pregnancy. So Dr. Florencia, this is something that actually really is the most incredible process. I think we underestimate how much human beings have bent biology in order to make this process happen, right?
Yeah, it is. It is something amazing. And as I said before, technologies are improving day after day, and we're getting such an amazing results. It's so exciting to see beautiful embryos coming from frozen eggs, patients who had their eggs frozen for a while, and then you see such an amazing embryo that ends. So we feel so positive once we see those embryos. And so yes, so really you said the most important in regards of the process. So I always tell the patients, I think again, so we talk and we use a lot of statistics because it really helps to understand a little bit the situation and to manage expectations. Although we are humans, we are not numbers. But I think it's important to understand that sometimes not all the eggs are going to thaw well. So on the day that we want to use them and we thaw the eggs, we need to see if they're alive or not. And sometimes we may lose some of them. With the new technologies, normally 90% of the eggs will be fine, but that depends on many factors. Then obviously when it comes to the fertilization, so it depends on the sperm quality. So if you have a good sperm, will have probably better results than when the sperm is poor. There is a mark of IVF ICSI there, but actually when we're having frozen eggs, it has to be ICSI, which is the injection of the sperm inside the egg, because the eggs are what we call denudated. So normally the eggs comes with a number of cells around the egg, that those are pretty necessary for the process of IVF or the fertilization. So when the egg is frozen, the egg has to be isolated, and therefore when we use it for fertilization, we need to inject the sperm inside the egg, which is absolutely safe technology, and it helps us to maximize the fertilization rate. And then embryo quality is something that we can monitor in the incubators. So nowadays, many incubators, they have a camera integrated, so they are called time-lapse incubators. So we can really access and monitor the embryos. Every 5 minutes, we're going to have a new picture of the embryo, and that helps us a lot to understand the chances of success based on embryo quality.
Amazing. I'm conscious that we need to get to some questions. So I've been busy scanning the many, many questions that we have and just trying to see how I can group them. One of the questions that I really would love to get to is the question of quality and quantity. How many eggs do I need to freeze, and what are my chances of success? So for me, when people ask me, they say it's very difficult to find what is the success rates for egg freezing. And in truth, that question, when we think about success, really is in a weird way like asking somebody, what are my chances of getting better if I'm sick? And I know that sounds a little bit silly, but if somebody asked you, what are my chances of getting better if I'm sick? The first thing you would ask is, what are you sick with? What's your underlying health? What age are you? Have you had any other exposures? And in truth, it's very similar with egg freezing. What are my chances of success really depends on your age, your AMH, your any of your menstrual factors, whether you have regular or irregular cycles, and then for example, any other menstrual conditions, whether you have any other underlying conditions like an autoimmune condition. A lot of women have autoimmune conditions. What your health state is, what are your exposures, whether you smoke, drink. We've just had a paper published, it was accepted today, about egg freezing, about the impact of vaping and its impact on fertility. So really and truly answering the question about success really does depend on the individual and their underlying health. And that's why I think it's important to allow people the opportunity to be able to just check in on as much as possible the personalized aspects of their own health. So that I think is the big question that everyone, the burning question, what are the success rates? And I think success is so dependent on the individual. Anything else to add, anyone?
No, I think that's real fact. So it's a personal conversation that we need to have. If you decide, if you're considering to freeze your eggs, feel free to have that honest conversation with the consultant, because we need to see in a case-by-case situation, what are we looking for? And based on that, we're going to have a proper plan to get to that point that we're aiming.
Yeah. So one of the questions asks about the actual procedure for how do you collect the eggs. So do you want to just talk briefly through that?
How is the procedure for the egg collection? Was it?
Yeah.
Yeah, so it's a very simple procedure. It's a low risk. It's a low risk procedure. So the risk of complications is 1 in more or less 5,000-10,000 cases. So what we do is basically the internal scan, so the vaginal scan. So we can see the ovaries that are going to show the stimulated follicles. The stimulated follicles are pretty big. Normally are between 15 to 23 millimeters. So they're very easy to identify. And there is a needle that is attached on the top of the vaginal probe. And so we have the view of the follicles, we have the view of all the pelvic structures, actually. And that's why it's so safe, because we can see all their structures. So we can see the bladder, we can see the bowel, we can see the blood vessels. And obviously, we don't go through those structures, but
You've muted yourself, Dr. Florencia.
Sorry. Yeah. So the needle is very thin. So we need to pass the vaginal wall. We only pass the vagina, and that's it, straight into the follicles. And then that needle is connected to vacuum system, so that goes aspirating the fluid that is inside the follicles, that is going to be collected into small tubes, and then those tubes are going to be analyzed by the embryologists, who are going to tell us one by one. So we have 1 egg, we have 2, we have 3. So at the end of the collection, we'll be able to know how many eggs we had altogether.
One of the questions is around, do you recommend taking time off around freezing, particularly if you're in a very busy job? For example, a doctor, you have stressed tiredness, how it affects the process and reduces the amount of follicles. And I would say really mental and physical and nutritional preparation prior to freezing your eggs should be no different to pre-conception. Like if you were planning on getting pregnant, you would want to invest in your health, you would want to reduce stresses, you would say, you know, your body, weirdly, we have this finely tuned evolutionary sense check where our bodies are so susceptible to stress. And if we are stressed, we tend to really suppress ovulation. And it's actually quite damaging from a genetic perspective, even from a DNA and a methylation perspective. There's lots of different ways that we can look at it. But stress can really impact people's perceptions, their experience, and their overall success. So I think taking time off to really just say, maybe if you can't take actual time off work, you can still really invest in just making sure you're less stressed. I can't take any time off from this little thing. Sorry. Never happened to me before. I'm on my own tonight, guys. I'm sorry. The stress levels are got out the window. Yeah, it is important to consider stress. It is important to consider. A lot of people try to just pack this into their busy lifestyles, and they're like, right, yoga at 4, meeting at 5, egg collection at 6, and it just needs to be really considered as something that is so important, and especially when you're investing so much in this, I do think really everyone should take a step back, prepare themselves financially. No, not financially. They're going to have to do that anyway, but prepare yourself psychologically and physically and nutritionally to say, I want to give myself the best possible chance. And in order to do so, I need to reduce my stress.
Again, that goes back to a question of to the point that is important to individualize and see what is stress for everybody. So what kind of stress, environmental factors can we change? But something that I want to make clear is not really necessary to take time off, because my perspective of things, I don't like somebody taking like 2 weeks of, for example, annual leave if they have 4 weeks a year to freeze their eggs. It's not really necessary unless you feel, oh no, my job is extremely high in stress. My boss is really like a bullying person. I feel very bad. So in certain circumstances, it could be good to have some days off, but it's not really required for the treatment itself. But it's important that you find a way of feeling yourself in a good position to go through this process that could be a little bit emotional and and stressful itself, the process. Sometimes things goes very smooth and they go very well, but sometimes we have bad news, we have a lower number of eggs than expected, or we go for a scan and you tell us, oh, you have a cyst. And sometimes this could also be overwhelming in some circumstances. So yes, it's important to have certain kind of preparation. So if for any personal circumstances you need to have some extra time, again, it's something that you should be speaking with the consultant, and we can find a way. We can talk about how many days are going to be important, what's the phase that is better to take time off, and we can also give a medical certificate for that.
There's a few questions here. I know we're over time, but I just want to answer a few more questions if both of you are willing to just give a couple more minutes. One of them is around birth control and egg freezing. So Dr. Florencia, there's one in particular, do I need to come off birth control? But there have been others saying, do I need to have my coil removed, etc.?
Yeah, no, we can do the egg freezing with the coil, so you don't need to have it removed. It's absolutely fine and it's safe. There are many studies and they haven't found any differences in terms of egg numbers and egg quality. In terms of the birth control, we normally tell the patients to stop it the month before. It's only in some particular cases that we'll need to give a different advice. So sometimes even for the AMH, for example, that doesn't change much with the birth control, but sometimes it does. So if I have a patient with the low AMH, sometimes I give them the option to to stop it for a few months, repeat it again because it's more accurate. So, but normally the short answer for the majority of the cases is you can continue with your contraceptive pill until the month before we start the stimulation. So then we do stimulation, and as soon as we finish with the collection and you have a period, you can go back to that. And if you have the coil, you don't need to have it removed. We can do it with the coil.
So there also have been studies. So we tell people if they're on the combined pill that they should come off it for 3 months before testing, because we can see we do see a difference actually in the data.
Yeah, this is what I said. But if I have a patient with a very good egg reserve, with a very good AMH, so let's say it's in the centile of 60 or 70, I normally tell them, so if you stop it, probably it's going to be a little bit higher, but still will be normal. But in some cases where you want to have a more accurate result because the levels were too low, sometimes we tell them to stop it for a few months. Yeah.
And what about the implant?
Well, again, the same. So the implant also. So some studies have shown that could affect like from 15 to 20% the levels of the AMH. So if it's really required, yes. But if it's something that has the implant because she was suffering with very heavy bleeds or very painful, she had it for a year or two, and since she had it, she was feeling amazing. I'm not going to tell her to have it removed unless it's really necessary to have a proper understanding. So is it a situation where is she willing to try to get pregnant sooner rather than later? Sometimes we say, well, then maybe you want to have it removed a bit sooner, but otherwise we can definitely do it with the implant as well. So the egg freeze, if all the parameters are good. Yeah.
Okay, and then the last thing is just the additional costs for thawing and implantation part of the process. There are additional costs for the thawing and implantation part of the process. Do you want to talk through that?
Yeah, I don't have the cost for that. I only have the cost for the egg freeze, as I said before. But that will be in the order of more or less 3,000.
Yeah.
So that's the ecto with the ICSI and the embryo transfer.
Yeah. So and again that somebody has asked, are there any tests that can be done on embryos for genetic illnesses, for example? And there are. If you have a family history of a known condition, you could get what's called pre-implantation genetic testing for a monogenic condition, so whatever condition that is. But typically what is offered in the clinic is pre-implantation genetic testing for aneuploidy or PGTA, which is where you are looking for the correct number of chromosomes. And those tend to be costed per embryo when you do the genetic testing of your embryos. What we would love to do is to be able to just follow up with all of these questions. Anyone who's put in a question, what we can do is we can collate them, follow up. Everyone will be sent a recording of this webinar, and what we'll do is we'll put your frequently asked questions in the bottom of the email so that you can get some answers. We have a full team of fertility advisors and really amazing care team that can help us to just answer any questions that you have. So I'm just going to finalize by saying thank you so much to both of you for giving your evenings, for bearing with me, and for giving us your experience and your expertise. And thank you for all of the lots of people who've joined us this evening. I'm really grateful for you. And if there's any feedback, any questions, anything you'd like for us to cover in our fertility talks, please do let us know. But Dr. Florencia, Jacqueline, thank you.
Yes, thanks so much, Shaki. Thanks so much for sharing this moment here, and thank you for hosting this meeting, Helen. Thanks so much.
I've got a QR code that I'm
yeah
bad at highlighting this, but there you go. Hopefully people can scan here and check out their fertility. So let me just say good night to everyone, and thank you so much for everything.
Thank you.
Good night.